Right now, it's a new era, I think, of anesthesia in general, that we're more important than we know or than we thought we were. And we're finding out that some of these little differences that we can make really can have a lot of importance. It's not just putting somebody to sleep and waking them up anymore and taking care of them just during the operation.
If you look at where our specialty has gone in a very short time and the ability of us to take care of folks that are just so sick that they should die, you know, that under a 25-year-ago anesthetic, that their chances of survival might be dismal. We can take that patient now and they can have a very successful outcome. That innovation, that flexibility, that drive to make it better is what brought us here. So it's reasonable to assume we should keep going. And the frontier of brain monitoring, or at least looking at what's happening to the very organ we affect the most, makes sense to me.
This is very much an information age. And so I think informatics and data analysis and decision support and things like that are becoming more and more the hot topic. Sure, we're going to still see some new drugs. We'll probably see a new reversal agent. We may still see yet another muscle relaxant. We'll see some cleaner cardiovascular drugs. Maybe we'll even find some non-opiate alternatives for pain relief. So there still are some, drugs on the horizon on the pharmacology side. But the issues now become more a matter of things like pharmacokinetics and delivery systems for those drugs, even delivery systems for gases for that matter. And when you go beyond the kinetics, you get to pharmacodynamics. You get to do the part about the individual patient response to a given blood level or a given end tidal level of gas. And now you talk about closing the loop.
Closed loop and automation of drug infusion in general can help you. If you have a good measure, a good drug, and good technology. Technology means that you have a good control algorithm. But you can't predict what will happen in the near future within 30 seconds. So that's where the human operator comes in. You have to guide the control system towards a certain target. That's similar to what the pilot is doing. The pilot is dialing the coordinates where the closed loop of his plane should fly to. And within these coordinates, the closed loop control or the autopilot in an airplane does a good job. But if you meet the limits of the control system, the human operator, in our case the anesthesiologist, should take over. Otherwise you will have overcontrol, which can become very dangerous.
One experience I remember in particular was observing a great closed loop system where, due to some surgical conditions, unintended hemorrhage occurred. So really life-threatening hemorrhage. And what was really interesting was to watch my colleagues spend all of their time focusing on how best to handle the patient crisis at the moment and never having to worry about what the system was doing in terms of monitoring the anesthetic depth and adjusting the medications. And to see that ability to free me up to do more attention on critical tasks without having to worry so much about what's going on with the anesthesia, that to me it gave me that glimpse of this is where I really think it, in the long picture or in the big picture, would really help our patients.
The forward-thinking people who really have thought this through kind of see the OR of the future to be a little more similar to the ICU of today, where an anesthesiologist, with the help of technology and other human-type assistants, could take care of significantly more people at the same time, and to be, with smart systems and feedback loops, could be able to be deployed in a more efficient manner like that.
I tell our residents, and I don't really think I'm exaggerating all that much, I tell our residents, I think that if you compare the anesthetic that I gave in the mid-70s, when I first started, with Morton and ether, when it first began, it was closer to Morton than what I did is to now. The difference in anesthesia in the last 20 to 30 years is so profound that I can't really make the comparison. Right now, a person who really is just beginning can give an anesthetic that I could not dream of giving 30 years ago.